How common is it to have lymph node involvement in stage 1A mycosis fungoides?
So technically, if you're stage 1A, it means you don't have lymph node involvement. So I'm guessing you were diagnosed as stage 1A, and then you're asking how likely it is. It's extremely unlikely. People with stage 1A have an excellent prognosis, and typically the disease isn't the cause of their mortality. Having said that, I would say nothing in medicine is ever 100%. And if you see this condition enough, once in a while you'll see something that doesn't behave in the usual way. So I'm not saying that you couldn't develop lymph node involvement in stage 1A disease, and that's why it's important to come check with your doctor and have your doctor check you out. But it's highly unlikely.
How often should I get scans to make sure that my MF hasn't spread into my organs?
I'll let Dr. Street answer this one.
Hi, everyone. The important thing about scans for Mycosis fungoides is to first have your MF, we'll call it, adequately staged at first diagnosis. And our practice is to do staging investigations, which include CT scan imaging at a time that an individual is first diagnosed, and thereafter perform the scan if the clinical status is changing, if there are new lymph nodes on clinical examination, or if there's any new findings of organ dysfunction that need closer investigation. But we don't do routine surveillance scans for individuals with MF.
I would add also to maybe Dr. Street that in patients who have early stage disease, so very minimal cutaneous involvement, we don't generally do scans in them at baseline, and that it would sort of be a case-by-case presentation, and that scans are maybe not indicated for everyone at baseline.
With MF stage 1A, do some patients do well with NB-UVB at lower amounts than the 2,000 millijoules that seems to be a standard goal? Is it really necessary to build 2,000? To build 2,000 seems really hard on my skin, fair skin that tans. I've only gotten up to 1,200 millijoules and even wonder if just 700 or 900 would be enough. So prior to answering this question, I do want to give our disclaimer that Dr. Street and Dr. Harden are giving us their opinion based on what they have seen in their own practice. Please do not consider this a second opinion. You should always discuss treatments with your physician.
So thanks for the question. When we talk about phototherapy for mycosis fungoides or cutaneous T-cell lymphoma, NB-UVB stands for narrowband UVB, and it's a type of phototherapy that has a very restricted wavelength. That's 311 nanometers. When we decide actually what amount of energy should be delivered to the patient, I don't look specifically at the amount of energy, so the joules or millijoules that's given. What we try to achieve is something called the minimal erythema dose, or the MED, and that is individual to the patient. So what we want after a dose of phototherapy is for 24 hours, you have minimally perceptible erythema. That means your skin is slightly pink or red just for 24 hours following your phototherapy. And that's really our target. And the longer that you go for phototherapy, the more energy you're able to tolerate until you achieve that MED, or minimal erythema dose. So really it's patient specific, and you do not want to be burning while you're in the phototherapy booth if you're trying to achieve a specific target of energy. I would say it's not so much the joules that matters, but more whether you're achieving that MED, and tailoring your treatment to achieve that without getting too much or burning while you're in the booth.
Have you prescribed oral retinoids for early stage MF1A, 1B in addition to NB-UVB treatments? Why and how long do you keep patients with good response on retinoid therapy? And reminder, this is based on the patients they have seen and not specifically on the person asking the question. That Dr. Hart and Dr. Street have not seen your records. So this is just an opinion based on what they have seen in their own patients.
I'll start maybe and then pass it to Dr. Street if she has anything to add. So absolutely, we use oral retinoids quite a lot in early stage cutaneous lymphoma, especially when patients are finding either topical therapy cumbersome or almost bordering on too extensive to apply. And we use it in combination with phototherapy because there is, I think, synergy between those two modalities together. In Canada, we are a little bit unlucky because we don't have access to the oral retinoid agent that has FDA approval and is used widely in the United States and Europe for cutaneous lymphoma. It's called bexarotene. So we can't access that here. So we've tried to make do with some of the other retinoids that we have, such as the isotretinoin family, the seriatine or acitretin, and then more recently, alitretinoin, which has, I would say, slightly better but less efficacy than bexarotene specifically. So the type of retinoid, I think, matters, and we do the best that we have. And then, yes, using it in combination with phototherapy, I think, is very useful. In terms of the duration of treatment, often in cutaneous lymphoma, the goal is to achieve a durable response. And then if patients are doing well, then we hold the course. It would be rare, I think, in somebody that I would stop treatment or stop the retinoid if their disease was responding to that course of treatment. We know the natural history over time is for early stage disease to grumble. And that we don't have a cure. So in patients that are doing well and tolerating the treatment, I would maintain them on that unless there was an indication otherwise to change or stop treatment.
I would just add a couple of additional points to Dr. Hardin's summary, just about the tolerance of retinoids. So some patients tolerate them very well with minimal side effects. And of course, if it's working, it's very gratifying to know that their skin is improving with the use of retinoids. It's important for us when we recommend retinoid therapy that we know that the individual's health is such that they can tolerate it and tolerate it safely. So one of the important things that we do when we are considering a retinoid therapy is evaluate the individual's liver function and liver health, and at times refer patients for specialized testing to evaluate the liver health. As well, we recommend to minimize alcohol consumption. It's important as well for any women of childbearing age to know to use adequate contraception while on a retinoid. And as well, some individuals, it works quite nicely. Others do experience some dryness of the mucous membrane, so whether that be dryness of the eyes or the lips. And so that is one of the complications of the therapy, or these potential side effects and potential health risks. And we just have a sort of a program to make sure that we're watching for those carefully.
Okay, thank you. And Dr. Hardin did mention about having different therapies available in Canada versus the United States. So it's a perfect timing for our next question, where we're going to talk about treatments. So just recognize that not all treatments are available in Canada and in the US. Can you develop multiple mycosis fungoides like classic MF and FMF? If yes, how is it treated? Who would like to jump in on that one first?
Yeah, I can take this question. So as it's mentioned in the question, so we know that mycosis fungoides is a very heterogeneous disease regarding the presentation. And we can have like different lesions look differently in different age groups and also in different, ethnicities and races. And also in the same patient, we can have different lesions. Sometimes they look very, very typical, meaning that it's like psoriasis or eczema appearing lesions, red patches, red plaques with some scales on top. But sometimes we get to see the more rare, variants of mycosis fungoides, meaning areas that are more like papular, areas that look like acne, areas that are, we can have like hair loss over them. And this is sometimes can be a mixture in the same patient. Sometimes that is making our, diagnosis more difficult but it's definitely something that we tend to see. We can see that also in patients who have both hypopigmentation and hyperpigmentation in the same patient. So usually in these cases, eventually the diagnosis is based on biopsies, but many times we need to to keep our mind open once we have a patient who has mycosis fungoides, that also lesions that look different from the lesions that we're used to see in these specific patients might be still the same disease or progression of his disease.
Yeah, exactly what I wanted to also add is that sometimes when the lesions change or start changing, that's a sign where we would like to look a little further into that and see if, for example, the mycosis fungoides is progressing to a slightly more aggressive disease or something like that. And that's why the same patient can have different types of lesions at the same time or progressively in time.
Great, thank you both for that. It was very good information. Our next question, when should a mycosis fungoides patient see an oncologist?
Well, it's very hard for me to tell exactly the point at which you should also see an oncologist, because the way we work here at MSK is that we basically see the patients together from the get-go. And but I would say whenever a patient feels like their dermatologist is starting to think that there's a need for a treatment other than just skin directed, then that's where probably the dermatologist starts having a role where they want to include a hematologist as well. But I think it would be good to see a hematologist anyways from the get-go, and then they will decide the pace at which they want to see you. Maybe it can be that you see the dermatologist more often than the hematologist, and the hematologist can see you just once a year or every 2 years, something like that.
Yeah, I can also add to that. There are different approaches. I mean, looking at different, institutions, and I totally agree that at MSK we go for one attitude, which says that usually the patients get to see both of us in our coordinated clinic. But there are some places that the patients get to see the oncologist only when they have like involvement of their blood component, that they have disease in their blood. In some cases, it's only when they need like chemotherapy, or only when they need like a hematopoietic stem cell transplant. So it depends on the, on the expertise of the caregiving physician. Some dermatologists are, have a lot of experience also prescribing and giving like the oncological treatments, chemotherapy, and the immunotherapies that are given today. So it changes from one place to the other. But I think that most important is that the patient, like Dr. Ghioni started saying, the patients needs to feel comfortable in the, in the treatment he's getting. It's never wrong to go to get and to hear also the other, discipline, if he's treated by an oncologist, to see what the dermatologist who is treating cutaneous lymphoma has to say, and vice versa. I think that working together is very important.
We have our next question is, we don't see a lot of pediatric patients, but we are starting to see a few more, is what type of doctor should treat my 6-year-old who was just diagnosed with mycosis fungoides?
So for pediatric population, I mean, there are like pediatric dermatologists who have experience in cutaneous lymphoma, but also all cutaneous lymphoma experts, they also treat like pediatric populations. So either a pediatric dermatologist, again, if we're talking about a case of early stage, if it's like advanced stage, so also the oncologist and hemato-oncologists should be involved. But in like very early stages, it usually starts with a pediatric dermatologist. And if he needs more experience, he can consult or refer to a cutaneous lymphoma dermatologist for a further assessment and treatment.
Okay, thank you so much.
Yeah, I would say same thing for the oncologist.
I'm sorry, could you repeat that? I talked over you by mistake.
No, I would say exactly same thing for the oncologist. There are lymphoma doctors that are pediatric oncologists, and I would start there and then see if there's a need for consulting with someone that does more, cutaneous lymphoma only. But yeah, same principle.
On our next question is, how often should a patient with mycosis fungoides have a PET or CT scan and or a biopsy?
So I can approach the biopsy issue, and maybe Dr. Guioni will respond to the PET scan. So biopsy, and we are, I think, also referred to that in one of the first questions. So usually the recommendation is to repeat a biopsy when there is a change in the rash. I mean, if there is a diagnostic biopsy, meaning that the biopsy was reviewed by a pathologist who, well experienced with diagnosing cutaneous lymphoma, and he decided that it meets the criteria, then we don't need another biopsy if the same, rash stays for long. But if there is some change in the rash, like new lesions appear that are different from the lesions that were biopsied before, or new lesions that appear after the patient has been on a drug that cleared completely the skin, if there is some sort of a change of what was used to be seen in that specific patient, then we usually repeat the biopsy. And the idea is to see whether the cells changed. We can also look at specific markers, and some of them have meaning regarding the treatment that the patient can get. We know nowadays we have some immunotherapies that target specific proteins that are on the outer membrane of the cells, and if we show that we have them, we can offer this treatment for the patient. So this has like a huge importance. Of course, that in patients that we don't have a diagnostic biopsy, sometimes we need to repeat biopsies until we get to the exact diagnosis to see whether it is a true lymphoma or something that just mimics lymphoma. And we know that some of the patients, it's very frustrating because they go through like many biopsies until they get the diagnosis. And sometimes still after 8-10 biopsies, it's still unclear. And sometimes this uncertainty is very, troubling to some of the patients and sometimes also for the physicians.
There's no rule for the PET scan. What I used to do is, unless the patient has a very limited stage disease, like really just one patch or something that really doesn't make me think of a systemic involvement, if it's just a little bit more than that, I do a PET scan at the beginning, and I look for, lymph nodes or systemic involvement in the body. If there are lymph nodes that are very active, then I try to do a biopsy of those and see if there are cells of the Mycosis fungoides in there, and if they are there, if they're really growing in there, or it seems like they're just passing by through the blood, because that's very different. In general, if the patient stays stable and doesn't really evolve, and the Mycosis fungoides is always stable and well controlled by the disease, by the treatment, I don't repeat scans unless I fear that there is a progression or something is changing. And just, be aware that Mycosis fungoides gets worse in the skin before it ever goes inside of the body. So unless it gets worse in the skin, there's really no big reason to test for, to test the inside of the body, like to do a full body scan. I hope that answers.
I have recently been diagnosed with mycosis fungoides. I seem to contract cold viruses at a significantly higher rate than my family or coworkers. Could this be related to MF?
So I can chime in on that.
Go ahead, Dr. Said.
Yeah, so there is some concern that with T-cell lymphomas, including skin T-cell lymphomas, there is a level of immunosuppression that kind of sometimes more than what we see in other lymphoma subtypes. And there is definitely, we know that patients with T-cell lymphoma or mycosis fungoides are more prone to having certain kind of infections like Staphylococcus aureus infections, which can be a pretty severe bacterial infection of this, involving the skin. So it could certainly be contributing, although we don't really have, clear associations with increased incidence of colds, as you described.
Can mycosis fungoides affect internal organs when skin still presenting as early stage?
Yeah, sometimes it can, that is why beyond a particular stage, we do imaging, because to make sure that, as we talked about, mycosis fungoides can involve different compartments. So skin is just one part of the picture, but also lymph nodes, the blood, and then less commonly internal organs. I think so. Unless somebody has very early stage disease, we end up doing imaging to truly stage the disease. But in general, most patients who end up having internal organ involvement will have a more extensive skin disease. That's usually definitely the more common presentation.
What is the association between EAC and mycosis fungoides? The EAC is what initially sent me to the dermatologist.
So erythema annulare centrifugum, boy, that's a mouthful to say. Please don't make me say it again. That's why we call it EAC. It is often considered, it's a reactive pattern in the skin. So when we see it, we kind of think about, why is this person having this rash? Their skin's kind of reacting to something. Sometimes it could be a fungus on the feet, like athlete's feet, or kind of something going on triggering an immune response. So it may have been your body kind of having a skin reaction to something going on inside of you or to part of your immune system.
Okay, thank you so much. And this is one I haven't heard before, so I hope one of you will have some input on it. Is, can mycosis fungoides cause aches which feel like pain in my bones? I always heard that it's an itch under the skin you can't scratch, but that's a new one for me.
That's right. In that case, I would probably look for other reasons for the symptom. I would not attribute it to mycosis fungoides, because definitely it's not one of the common things that we see.
I agree.
Okay. I'm early stage MF. I use Triam 0.1 and sunbathing to control it. I sometimes have few small red spots. I do not know if they are MF or not. The cortisone works. Is there a way to know without biopsies if I'm just treating other things or any spot is likely to be MF?
Well, that's a tricky question, actually. I mean, in dermatology, we often say we can always, mycosis fungoides can look like anything, honestly. So it can be very confusing. It can be a bad hand eczema that actually is cutaneous T-cell lymphoma. So really, you need to talk to your doctor about those spots. They should take a good look at them, but you may have to have a skin biopsy to really know whether or not it truly is mycosis fungoides.
Okay, thank you. And then this is the question that I saw that I had touched on already, is, can mycosis fungoides be cured?
Yeah, theoretically, in patients with advanced stage disease, sometimes, we take them to a transplant when they get allogeneic stem cell transplant, where they get stem cells from another person. That is a potential curative option, but it also comes with a lot of side effects and a lot of burden. So definitely it's not an option for everyone, but especially for people where, that present with very aggressive disease, we do think about it earlier than others.
So after many years of early stage slow progressing MF, is it possible that MF can become more aggressive? If so, what can be done to slow progression?
I don't think we have an answer to what can prevent such a change in character of the disease. But yes, it can happen at any point. For most people, we do see like a slow progression over years where they would move from early stage to advanced stage. However, there are certain patients where it can act a little bit, it can be that progression can be faster. We don't necessarily have any data right now to tell us, who is going to be that person where it's going to, progress faster. It's mostly, just for every patient, it's going to, it's going to be a very individualized treatment and progression. And that is one of the reasons that, we do definitely recommend that for mycosis fungoides, cutaneous T-cell lymphoma, that patients, are treated with a multidisciplinary team, because the treatment is so nuanced, and not everything has to be I mean, there has to be a balance between under treatment and over treatment in this condition.
I live in a dry climate and I'm thinking about moving to a climate with humidity. Which is the better climate for mycosis fungoides?
Well, from a skin perspective, a little moisturization in the air is not a bad thing. Minnesota winters are very dry and cold, and that does tend to kind of make your skin barrier break down a little bit more. So you definitely have to, I think, moisturize a little bit more in Minnesota, maybe compared to Florida in the winter months. Also, different topical agents can be more drying, like Bexarotene gel, because it's got an alcohol base, can be a little bit harder to use in really dry climates where you don't have a lot of moisture in the air. Having said that, if you're really hot and humid and sweating a lot in a place that's very warm and humid, again, that is also losing water out of your skin, and that skin barrier can break down from that. So I don't know. I think you have to find the perfect climate, one that's not too humid or too dry. I don't know. I think maybe Hawaii. I don't know. You can be too hot and humid, and you can be too dry and cold. So it's a happy medium. So you should go wherever you need to move, basically, and we'll try and help you with it.